So just to introduce myself, my name's Oscar. I'm one of the registrars here based at Sydney. For those guests joining us, as I said before, normally on education days, it's a bit more broken up and we have things like workshops focusing on sort of practical skills and then maybe a simulation as well, which obviously we can't do today. One thing we can do today is we always try and cover a topic from the DipPHRM, so from the diploma. So this is just a quick sort of short and sharp talk for about sort of 20 minutes, just focusing on bariatric patients in pre-hospital and retrieval medicine. So we'll just go through that. I've put in the elements of the DipPHRM curriculum. Is that coming through? Yeah, elements of the DipPHRM curriculum coming through. You don't need to read them all, but just be aware that it is on the curriculum. So I think is something that could easily come up in exams. I think it's an easy modifier for things like a lot of practical stations like RSI. So looking at our service, I had a little look back through the last 10 years, and I think like all charts with sort of obesity and large patients, you can see a general upward trend. There was definitely a big jump last year where we moved just over 200 patients over 120 kilos, and I think that's probably going to be a reflection of COVID. I'm sure, everyone else has found that with COVID, it tends to be patients with higher BMIs tend to do a bit worse and need a bit more ventilatory support. So what we'll do, I'll just talk through from a physiological perspective, A, B, C, D, and E. I'm not going to dive too deep into the physiology because really what I want to make this about is practical things you can do on your next shift when faced with a bariatric patient. So first of all, we'll start with airway. Now, I think the most important change with a bariatric airway is positioning. And I really like this diagram because I love how it's got the airway axes on. And as you can see, the picture on the left, you've got someone lying flat with head against the bed. And you can see that with his head against the bed, his axes aren't very well aligned. So you've got his oral axis, which is OA, is greater than 90 degrees away from his laryngeal axis. So the picture on the right, you can see just by ramping him, just what that does to the axis, you actually get nearly all those axes between the sort of 12 and 2 o'clock position. So it's going to be much easier to pass a tube. There are lots of ways you can achieve this. So you can see on this diagram, you've got pillows. I tend to not like using pillows for airway because I find hospital pillows just seem to be made of sort of like compressed, sort of like air, just in a kind of a air thing, and you kind of get people nicely positioned, and then they just sort of slowly compress over time, and you lose that position. You've got these foam blocks, which some anaesthetic departments and EDs have, but obviously you wouldn't have in a retrieval environment. The bottom left is a pneumatic device, which seems to have that patient in a nice position, but it's probably a bit impractical. And finally, you've got sheets. And I actually really like towels more than sheets because I find they're easily available. You can just pick up a whole heap when you're at the actual hospital. If you're there, get your patient nicely positioned. Obviously, in the pre-hospital environment, you won't have that much sheets or towels. I mean, this looks like they've almost raided a laundrette with the number of sheets and towels. So I think options are using packs, certainly using your Kendrick extrication device can help, and just packing with whatever you can to get that position. And often, we know these patients do better sitting forward. I'll just turn that off so there's no feedback. So often we know these patients do better sitting up. So we often get them sat up, lie them down in that position, then actually sit them up for the pre-oxygenation phase and lie them back again. This is a picture of one of our registrars, Chris, who kindly sent me some images from a difficult bariatric job he had as a primary recently. The paramedic was kind enough to take pictures and also kind enough to draw him as an angel, which I don't think many paramedics would have drawn me as an angel. But looking at the position they've got there, if you just zoom in and see this patient's in a really nice position. I've put a gold bar on, so you can see you've actually got him at tragus to sternal notch. And actually, they haven't used nearly as many sheets as in that previous picture. And what they've actually got is this pneumatic mattress where they've just inflated the proximal sort of third or so. So you can see they haven't actually had to use that much to get him in that position. You can see there's maybe a sheet or so, something blue, which is probably a roll. And I suspect if you look just under his hair, that orange thing is probably going to be a SAM splint bent into a W or M shape, which is something we use commonly on primaries. Just a common issue that I see with ramping patients, and I noticed this a lot with COVID last year because I felt there were a lot of intubating a lot more larger patients with that, is a common mistake I see, particularly with juniors, is actually in achieving that position. We spoke before about aligning the axes. this is the same image as before, but I've gone on paint and I've put a yellow bar where I think the guy's spine is, so pretty flat on the left, and then on the right is sort of curving at the thoracic cervical area to go up to his head, and a big red dot where his sternum is. And the reason I say this is often with moving the bed to achieve a good position, I think there's lots of nice things about having the bed slightly head up. We know that fat's actually going to be pulled down by gravity. You're not fighting it so hard. And actually, from a ventilatory point of view, people will fatigue less. You've got better VQ mismatch. But I think there is a trap with it. And I think the trap is if you're ramping a patient, you can easily think you've got them in a nice position when you actually don't. So what I'm going to do is I'm just going to move this slide by slide so you can see I haven't changed anything. And this, I think, is a common sort of almost optical illusion your eyes can play. And I think it's something you just need to be aware of. So let's pretend I'm holding the patient's remote and I just press that back up button. So I'm just lifting the back of the bed up. As you see, as this guy rotates up and comes through, if we get that bed to sort of 45 degrees or so, you can see looking at him now, if I was to put that gold bar back on, I could easily come in. And I often like to kind of stand to the side when I'm checking the position. I could easily come in, arrive at a hospital and they say, yep, we're all perfectly positioned, and actually say, yep, that tragus looks bang on level with that sternal notch. But actually, the axes, if you actually look at the axis, they haven't changed at all. All we've done is just changed our frame of reference. Those axes are just as bad as the axis that we had when the patient was flat. And I think the reason why that is because if you actually look at the problem with obese patients and airway positioning is this is the same patient. So on the left, you've got the CT brain. I've colored in the fat at the back of the head, which is orange. That's pretty much normal. But look at this guy's chest. You could pretty much fit twice his almost thorax within that, just surrounded by. So the problem in these patients is their chest is lifted up. Look just how high up his spine is. And we need to bring the head up to meet that, to maintain the right position. So for this guy on the right, who's appropriately positioned, if he was at the same angle, that's actually what he would look like. So I think just make sure that you're actually seeing, is the head being brought up to the chest, and you're setting yourself up for success right from the start. So next question is, does obesity alone constitute a difficult airway? Well, I think it does. And I think, looked at lots of papers for this. And I think the real question is, well, how much does it make things difficult and for what modes? Starting off, just going left to right. So laryngoscopy, there's a bit of a mix. I think it depends on how you design your study. If you have a patient like the one before and he's just lying flat on an operating table, it's going to be really difficult. But actually, if you optimize his position, it's probably not going to be that much more difficult. There are issues with lots of soft tissue in the mouth and upper airway and some crowding there, which probably makes it a little bit more difficult, but it's probably not as difficult as we think. There are obviously issues with risks of aspiration with high gastric pressures. LMAs, similarly, it was a lot less literature and a bit of a mixed bag, with one paper even saying they felt some LMAs worked better, and that's probably just because there was more soft tissue to help seat them. I think the real important thing with bariatric and airways is actually these last two options. So this bag valve mask and front of neck access. I think bag valve mask is really difficult, or more difficult, because we know these patients have a lot more upper airway soft tissue. A lot of these guys will be big snorers and have sleep apnea at rest. And also the sort of contours of their face are often lost a bit, and it's quite hard to get that seal. And it's definitely hard to get your hands in and actually find that mandible and lift it up towards the ceiling. So I have a very low threshold to use adjuncts anyway, and I would probably be using one straight up, like an oropharyngeal or nasopharyngeals, if patient would tolerate it. Surgical, again, you're not going to be able to feel your landmark, so just think how it's going to modify your technique, probably with a big vertical midline incision, and then sort of bluntly dissecting down and feeling with your fingers till you can feel some anatomy to get a landmark. But you can imagine some of these enormous necks, if you go slightly off to one side, it could make a nerve-wracking situation more nerve-wracking, but it's still doable. Coming on to breathing, so there's all these changes that you have to learn for your primary exam, and I think they're important to know and understand why it changes what we do. But actually, if we just zoom in on the practical things that we'll do if we were to move a bariatric patient on our next shift, I think the ventilator settings are probably the big ones. So first thing is, with your tidal volume, remember that we're going to be calculating that tidal volume based really sort of on the ideal or adjusted body weight. Just looking at this picture again, it's the same CT scan on the right-hand side. You can see, although this guy might be 200 kilos, his lungs proportionally are actually, that of a normal person. If you dial up his tidal volume based on that, you're going to cause some barotrauma. Second thing is PEEP. I really like PEEP in these patients. I think just sort of a slow incremental increase in your PEEP. We know they've got a heavy chest wall. They've also got a big abdomen that's pushing that diaphragm up, and they have a bit of atelectasis. So PEEP's definitely a friend in terms of combating that. Just in terms of interventions, so here I've just got, I don't know how well that's projecting, but that's just showing some normal lung sliding on the right with a bit of a comet tail there. If I just draw your attention to that ultrasound there, and you look on the right-hand side of the image, you can see the scale, and you can see the scale goes right down to, so that's 3.8 centimeters is the entire depth of that. And that guy's pleura is sitting around 2 centimeters. Now, if you imagine the patient on the right, a large patient, you're probably not even going to see pleura at all on that standard view. So I think you just need to increase your depth on ultrasound, because it's easy to misinterpret another white line in the soft tissue, whether it's a sort of fascia or sort of muscular plane, and falsely interpret that as no lung sliding. And just finally, if you think about that patient, let's say, it's going to be more difficult to tell clinically they do have a pneumothorax or hemothorax, but if you do need to decompress them and do, say, a finger thoracostomy on this patient, just imagine on that scan where those patient arms are and where you're actually going to come in. Look at the distance you're going to have to get before you actually hit that guy's ribs. So I think for me, the things I would do in a bariatric patient to adjust my technique would be, one, I would make a larger skin incision, because you're going to need to get more instrument and more of your sort of hand in there to get to the right place. I wouldn't stress too much exactly where my skin incision was. I'd get it in the right place. But I think what I'm really trying to drive at is where your skin incision is and the level of the chest where you actually puncture through the pleura can be two very different places. So I'd make a skin incision, blunt dissect down. I often find with my Spencer wells, I can almost like scrape the ribs, almost like a sort of rack of lamb, and kind of feel them. And I think I would probably just pause there and just make sure I'm not going too low and I'm getting a nice high placement as I puncture through. Because standard landmarks, if there's a lot of breast tissue, the nipple could be anywhere, and some of the normal visual cues to make sure you're in the right place might not be there. Now, if you are going to decompress this guy's chest, let's say, I'd say most of the time we're probably going to RSI patients if they've got something else going on. And we'd normally just do a finger thoracostomy. You can see, looking at the soft tissue, that track's going to close up really quickly. So you've got some options. And, the standard option would be a chest drain, which is depicted up here at the top, but that can take some time with suturing and dressings. Another quick option would be actually to put a small cut chest drain, or even an ET tube, because if you just tubes the patient, you will have tubes available, including the longer reinforced tubes, and you can just pop that into the chest. And the goal of that is really just to splint open that soft tissue. But I think it's just important to hand that over to the ED team so they don't wonder what happened during your intubation. Moving on to circulation, I think the main issue here I want to focus on is access. So access-wise circulation, we know that we've all had that experience of finding them more difficult to cannulate. Just going from the top down, so cannulas, I think more difficult to cannulate. Most pre-hospital services now carry ultrasound, and I think most of us are pretty comfortable at cannulating deep veins in larger patients. I think the thing to be aware of is making sure you've got long cannulas, use them if they're available, because often you've got a bit of pressure on the soft tissue from the probe. You're actually pushing down with your cannula as well, and you actually are indenting the soft tissue quite a lot. And I often find that actually I'm only getting flashback and advancing at the kind of distal sort of 5 mils of the actual cannula. And then when you release that, it's very easy for that soft tissue to move back, the cannula stay flush with the skin, and actually you go back and find that line's blown. This next one is just showing that syringe and needle is just showing IM. Just be aware that if you're giving an IM injection, think about where you're going to give it, because you can imagine for a lot of these, you're actually probably giving a subcut injection if your needle's not long enough to reach muscle. Next, IO access. So we've got 3 IOs here. Your largest IO is yellow, and I never did understand why for IOs they decided to reverse the colors, with yellow being big and pink being small. But yellow is the biggest, and it's 45 mils. Now, if you look at that diagram on the right-hand side and just mentally scan down that person's skeleton and think where your IO sites are, and you can very quickly see you're going to lose a lot of options. Probably the best option is going to be medial malleolus, as proportionally there's less fat here than elsewhere. And finally, central access. So central access, I think, can be really useful. And I would have a lower threshold for getting central access in certain clinical and logistic situations with large patients, particularly for transfer, because I think it's very easy to have that sort of scene time or job time actually just kind of start bleeding and blowing out, just because, you try a cannula here and it hasn't quite worked, we've gone back, or what's you got on this hand? And, central access in these patients, I think many times might be the way to go. It will be more difficult because things are deeper. And I think you need to be aware that actually in those skin folds, they're probably less hygienic and it's a much higher risk of infection. And I did work at one hospital where there was a story of a patient who had an IJ central line put in the ICU, a very large patient, went down to CT, and the CT scan actually commented it actually did exit a skin fold and go back in. So if you went to this guy's neck and actually pulled the skin folds apart, you could find the right skin fold, open it like a book, and actually see the central line come out of the skin and then go back into the skin. So that's just I've got you from a IJ point of view. Disability, really not much here. Just that, we know type 2 diabetes is more common in these patients. They often have impaired fasting glucose. Exposure, a couple of things here. So they've got higher intra-abdominal pressure. They've got a big belly pressing down. They're going to have higher gastric pressures and be higher risk of aspiration. This is a right upper quadrant view, an ultrasound from a fast scan, and just shows a nice strip of perinephric fat, which I think in a rush you could misinterpret as free fluid. But if you look, it's actually on the wrong side of the peritoneum. There's a little bit more echogenic than you'd expect. Finally, I've popped look in skin folds. You can imagine how difficult sort of actually doing a sort of blood sweep is in a penetrating trauma patient. If someone's been stabbed, 7 times with a screwdriver, they can be hard to find those wounds anyway, but particularly if there's skin folds that are moving and he's lying in a different position. Finally, that's the Lund-Browder chart. So just speaking on burns, Chris, I hope from Auckland you didn't have to move many large burns patient at that volcano, but you can imagine that calculating fluids and the actual percentage of burns is going to be really difficult because their body surface area is completely out of whack. So I would probably just elect to put a IDC in and sort of titrate a urine target for that, for my fluid management. Any benefits to being large? There are actually some papers here. So the top one's actually blunt trauma, talking about how some of the organs are displaced more upwards by the rib cage. And you're also surrounded by this huge amount of fat, which can actually protect you from certain injuries. Definitely has a protective effect in penetrating trauma. So if you're stabbed with a short knife, it might not actually reach anything important. And this bottom left article is one from something called Science Focus, where they did an experiment to see how fat you'd have to be to stop a bullet. So if you're shot with a handgun, a 9mm from 10 meters, you need 60 centimeters of fats for it to prevent it hitting the peritoneum. So just quickly finishing up. So drugs, a whole heap of different things change with drugs. I think really the most useful part here is probably just learning those just to get through your primary exams. In terms of what it actually changes on a practical basis, I think just making sure you're calculating your weights right, going off their ideal body weight, and probably just appreciating that lipid solubility and in the volume of distribution. So just in the final 5 minutes, just speaking about logistics. So this is on the DipPHRM as well, and it was something that was sort of new to me coming into pre-hospital retrieval, was just that kind of girth versus weight issue. And actually, quite a lot of the times it seems to be girth that's actually, and the patient's width that's actually limiting you. So in terms of getting a patient out, this picture on the right was actually from Chris's job, and you can see there's police rescue there with some sort of limb straps there, which they can use to help extricate. But you can see it's going to be very challenging to move that guy out, even with those. This device on the left is essentially almost like a hover mattress, so almost acting like a little hovercraft, which is used to extricate patients. In terms of just quickly going through our weights, so on our road vehicles, we've got a striker. We also have a bridge on there as well. So we tend to aim for a patient weight of less than 175 and 67 centimeters of width. But I think girth and width is the thing that's going to limit you before weight does. And as I was doing this presentation, writing it last week, I was actually got a call out to a patient who we needed to retrieve. Who was 140 kilos, who'd had a subarach. So I actually used that opportunity just to take some photos. So just showing, this is our standard aircraft cabin setup. So we have what we call an RSA, retrieval stretcher assembly, and that sits in the east to west configuration, like in this photo. That generally, we aim to have a patient less than 135 kilos and only 57 centimeters in width. Now, that's how we have it when we take off. When we load the patients, we tend to have them in the north-south orientation. So for this patient was 140, we took our SPS, which is our special purpose stretcher, and that actually can nearly take a double weight of the previous ones. That's 260 kilos. I'll put a photo of the foot plate in. It needs a different foot plate, so it does take a little bit of time before you set off just to get it installed correctly, and that we have in the north-south configuration for both. There are some advantages to it. So this was a photo from my job last week with the large patient, and that's the patient all loaded in. You can see that actually there's no restriction on width with this. It's literally just defined by the aircraft. But on that right-hand picture, that's me standing at the back of the aircraft facing forward towards the pilots. And actually, you can see where my left knee was. It was pretty much sort of up against that patient. The SPS do have oh, sorry. Yep.
I was going to say, just to clarify,
yeah,
because you've got written there max weight 135 for the RHS stretcher.
Oh, yeah.
If we land at a primary scene and the patient is 200 kilos, yes, they're going to overhang. Technically, we can still put them on that stretcher. The limiting factor is what the PLD can lift.
Oh, okay, yeah.
So we would have trouble getting seatbelts around that patient potentially, but if they were a 6'5" patient who's 160 kilos, our length will be a problem, but they legally can be on that stretcher.
Okay, yeah.
It's just that if we, in our secondary scenarios, we know
we screen for that weight.
For strapping down, we'd be better off doing that because we also know that in our basket, in our winch basket, we can put a much heavier patient at 135 kilos.
Yeah.
And they'll go on that stretcher setup. Not ideal, but doesn't mean that we then go, sorry, I can't transport you, we need to come back.
No, of course, yeah.
Just have to try and make it work. We have extension straps for our seatbelts to try and achieve safety for the patient, but it's possible. Just we use those limits. They're not absolute maximums. They're sort of what we would
have on our protocol to screen. Yeah.
To the better stretcher system if we have that opportunity.
Yeah, brilliant. No, thanks for.
Because we've had primary cases.
Yeah, I'm sure.
In the bush over 200 kilos that we have then put into the helicopter, and all we have is the RHS stretcher.
Yeah, I see. Yeah. No, thanks very much for clarifying that. Yeah, and one of the things I really liked actually about using this is my first time using the SPS stretcher. It's got these sort of this sort of like netting, almost vest thing, which sort of clips and actually allows really nice access to the patient. You can easily drop that down and do an ultrasound if you wanted to, and still access the patient. I actually think it'd be great if we had that almost on even the other ones, because I think it keeps them really nicely contained. And you can see on the picture on the right, I've almost treated it like the netting you have on an international flight by your knees. I've actually got notes, and there was actually some drugs there because this patient was quite hypertensive. So like we mentioned the PLD. This is our patient loading device. So this takes a much larger weight. And this can actually go higher. I think the main thing just to appreciate with this is that you have got the patient stretcher and monitor to take into account as well. Finally, on the winch, so I had a chat with some of the crews about this as well when I was doing this presentation. So technically the max load on the winch, and I've put a picture in the bottom right from the winch. So generally it's 249 kilos there. It did actually used to be higher on the same winch, and they've brought it down. It does drop a little bit if you're below zero, but that'd be quite rare for us to operate below those temperatures. The slip clutch I've actually put in there, and actually the slip clutch won't actually start slowly paying out cable as a safety mechanism until around 680 kilos. So there's actually a huge margin of safety for this. And you can see that actually if your doctor, I think we're meant to be at a max sort of 110 kilos with all our stuff on, and actually the stretchers are around 10 kilos. We've got other things on as well. You can see you can quickly actually chip away at that load weight pretty quickly. Just a reminder that from the Sydney guys that we do have a bariatric protocol, including a sheet that we can fax, and ACCO often help fax to the receiving centre to help get them measured. I won't go through this now, but it's just something to be aware of. So just in summary, I think in terms of the real things with bariatric patients, the main thing is to adapt to the physiology and just think about what things it's actually going to change for you on the job in terms of airway positioning, airway plan, finger thoracostomies, changing your ventilator settings, access, exposure. Think logistics, and I think often just having a good plan ahead, and the paramedics are the logistics experts and often help guiding that. Certain services, we certainly have what we call multi-purpose vehicles here, and I'm sure in your other services as well you have similar ways for extricating larger patients. And I think just plan ahead. And this was just from Chris's job, and I just like the picture on the left is pre-RSI. And you can look at the road paramedic, they met at her face then, and then look at her face on the right post-RSI. And I think that's probably what we'd all be feeling. So, yeah, thanks very much. I don't know if there's any final questions. If not, it's got, oh, yeah, just at the back.
Yeah, great talk, Oscar.
Yeah, thanks, mate.
You covered pretty much everything there. I'll grab the microphone.
Yeah, for sure. I'll pass it up.
Online.
Yeah, there you go, Alex.
Thanks, mate. Yeah, awesome talk. You talked a bit about pressures. You sort of alluded to the extra thoracic soft tissue and also the diaphragm sort of pressing up and requiring a little bit more PEEP. But I guess just distending pressure for the lungs is also often very much higher than we're sort of traditionally comfortable with. And you combine poorly compliant lungs in the context of a viral pneumonitis with obesity, and suddenly you're looking at scary high pressures. So unofficially, we've always felt, look, it probably doesn't cause the same barotrauma because the alveolar pressure is matched, if you like, almost like a scuba diver by sort of extra thoracic pressure. But I was just wondering if you'd done any reading on that.
No, I didn't go too deep into that. I did see some. I mean, there were different protocols. Like I found one from the UK on a certain looking at different ventilator settings and having a protocol. But I think you're totally right. And I think that's either going to be if you're in a volume control mode, considering adjusting those alarm settings and maybe just anticipating that high pressure, or in a pressure control mode, going higher. But I agree. I think it would make sense what you say in terms of it not being quite so dangerous, because that pressure is mainly coming from, fat on that, as opposed to a distended alveoli saying I can't stretch anymore. And
lovely. And then I guess a final corollary of that high pressure requirement is that your rescue technique of choice may therefore change if you're going to overcome the
pressure on an LMA.
The seal of an LMA, for example.
Totally.
That you may quickly decide it's going to fail, or if you are using it again, just don't forget to sit the patient up, whilst you buy time and re-oxygenate.
Yeah, no, that's a really good point. Great. Yeah, totally.